Thank you everyone for joining today's webinar, Best Practices for Preterm Labor Triage, a conversation about shared decision-making. My name is Susan Hepworth, and I'll be facilitating today's webinar, which is hosted by Hologic. Today's agenda is as follows. After my very brief introductions, we will hear a conversation from Dr. Richard Broth, a maternal fetal medicine specialist and medical director at TLC Perinatal PA in the DC, Maryland, Virginia area. We're also joined by Dr. Charles Hurd, an OBGYN hospitalist and the medical director at Alina Health in Minneapolis, Minnesota. And we are also joined by Jessica McNeil Santil, a certified nurse midwife in the Dallas, Texas area. Following their conversation, we have allotted time at the end for question and answer with today's webinar attendees, and we will wrap up then at 3 p.m. Eastern.
So we are happy to be here with you guys and hope to have a nice conversation regarding best practices for preterm labor triage, a conversation about shared decision making. So we thought that it would be really nice to start off with a case presentation. This is a common scenario that will be a springboard towards the conversation that we plan on having. So in a patient's prior pregnancy, she's a 38-year-old gravid 2, para 0101, with a history of preterm delivery at 26 weeks gestation. In her prior pregnancy, she had no risk factors. The only thing that happened during that pregnancy before her delivery was in early pregnancy, she had some vaginal bleeding, which resolved. In the current pregnancy, obviously, she has a heightened sensitivity because of her history. She began having contractions at 21 weeks gestation with no cervical changes, either digitally or seen by transvaginal ultrasound. She was evaluated in triage around 26 weeks when she came in complaining of significant pain, and there were some contractions that were seen on monitor. A digital exam was performed immediately. The cervix was documented as soft but closed. The patient was admitted, given steroids for fetal lung maturity, IV fluids, magnesium sulfate for neuroprotection. She was discharged home 24 hours later when there were no cervical changes seen and no further contractions. Over the course of the rest of the pregnancy, there were a few more visits in triage with prolonged evaluations, and she continued to follow up until ultimately delivering at 39 weeks. What we see on this slide is that we haven't been very successful in decreasing the preterm birth rates over the course of the last, let's say, 10 plus years, all hovering around 10%, which means that the interventions that we have not gotten us to the point where we have decreased the percent of preterm birth in this country, and we'll show you on the next slide that it varies geographically, but most states, as you see, are in that second tier between 9.5% and about 12% preterm birth rate. What we plan on evaluating or talking about today is not how to decrease the preterm birth rate, but really how to react to patients and be able to target our efforts towards patients who may have a higher risk of preterm delivery. There are interventions and aspects of preterm birth that are being looked at in terms of decreasing the percentages. That is not our goal today. Our goal today is to talk about the diagnostics of it and then what to do to help prepare patients. So the reality of preterm labor is that 50% of patients who are hospitalized for preterm labor ultimately give birth at term. And it's really at least 50%, it's probably more than that. And at least 80% of patients that show up in triage with complaints who aren't necessarily hospitalized for preterm labor, but evaluated for signs of preterm labor, go home either that day or soon after and do not give birth until term. And then fewer than 10% of patients with a clinical diagnosis of preterm labor actually give birth within 7 days of presentation. So I'm going to throw this out to my colleagues. What is the importance of accurate preterm labor assessment? Why do we care about being able to accurately assess when someone comes in as in preterm labor?
Yeah, thanks, Richie. So much of preterm labor evaluation is not about the diagnosis of, yes, you are someone who's going to deliver preterm, and therefore we need to do X, Y, and Z. So much about it is risk stratification to realize who is at lower risk and who is at higher risk. For instance, if you have 10 patients present to triage, each one of those patients is going to have a different degree of risk of their risk to deliver preterm. If we were to admit all 10 of those patients to the hospital, as the last slide said, maybe only one of those 10 is going to deliver. Yet now we've brought 10 patients into the hospital. We've spent 2 to 3 days with those patients in the hospital. They've received betamethasone, magnesium, medications that may have no benefit for them because 90% of them will not deliver. These may also be patients who have come from an outside hospital, a site where maybe they do deliveries only down to 34 weeks. And so you have patients who present at 28 or 30 weeks. These patients get evaluated and maybe even sent into another tertiary hospital. So they have to go through the transfer process as well. On the flip side of that, if we take those 10 patients and send them all home, now we've missed the opportunity to treat those patients with magnesium, betamethasone, antibiotics. We've missed the opportunity to get them into the right setting, the right type of hospital if they are at risk. So the real process of preterm labor evaluation is stratifying the risk for these patients, finding out who is most at risk to deliver preterm so those patients can get brought into the hospital, medicated, evaluated, and the patients who are at least risk can go home and can follow up as appropriate.
And thank you, Charlie. And to kind of backpack off of what you were saying with the importance of assessment, whether our patients are being seen in a small rural facility or in a large teaching facility, the nurses, the bedside nurse is that first line in assessment of the patient. And so ensuring that the patient gets an accurate cervical exam, that we're able to assess whether or not she is having contractions. If we're collecting an FFN, whether or not that's collected correctly. It's typically the nurse that's doing that. And so backpacking off of what you said with that stratifying our low risk patients versus our high risk patients, it's important that the nurses have good processes in place to quickly and accurately stratify those patients and get those assessments done so they can provide the provider with the most accurate information.
And I hate to talk about cost when treating patients because that should be the last thing on our list. But with healthcare the way it is, it really is upfront in how we take care of our patients. And the amount of cost that goes into bringing patients into the hospital, the amount of resources it takes, the amount of nurses it takes to manage an antepartum service. We used to have antepartum services full of patients who were on magnesium for days on end. And thankfully, we've gotten rid of that portion of patients, but we still have plenty of patients that get sent into the hospital, probably unnecessarily receiving medications that are unnecessary, receiving nursing care and provider care that we can limit. And from a patient experience, most patients are going to be much happier being discharged home, but they want to make sure that they get the evaluation that if they are at risk, they will be treated appropriately and have every opportunity to limit their chance of going into labor. And if they do, knowing that their baby will be prepared for delivery if it does come to that. And they'll be in the right setting. Again, having those outside rural hospitals that don't have the ability to deliver preterm babies, making sure that those babies can get to tertiary centers where they can be well cared for.
Yeah, we all know that it doesn't take long before the hospital comes knocking on our door to try and justify all those admissions. And so when you're talking about patient experience, it's not just the experience in the hospital, but even afterwards, if they're fighting bills because it's denied, that also is a big thing. So as much as the finances don't play into our clinical discussion, I think they do play into the overall discussion of how we can best utilize the resources for the right patients. And I guess that leads into the timing of antenatal corticosteroids, which is not really the focus of what we're talking about, but definitely falls under the purview of what we're talking about, and the ability to use steroids to maximize the benefits to the fetus and minimize potential risks. Go to the next slide. So up to 2020, the quality metrics when it came to antenatal corticosteroids were really, the incentivization was to use antenatal corticosteroids very liberally. The idea was, or the metrics were, did a patient receive antenatal corticosteroids at any point before delivery? It was not specifically focused on the timing as it relates to the delivery. Starting in February of 2022, the Society of Maternal Fetal Medicine really changed the quality metric for optimal timing, which would be an administration of antenatal corticosteroids within 7 days of that preterm birth. And we know when steroids are administered within 7 days, they are optimally effective. So there are studies that have been done that show that our timing as clinicians in terms of using our clinical acumen is really not so great. We're somewhere between 20 and 40% of patients that show up that will deliver within 7 days actually get a complete course of steroids. And we know the benefits of administering steroids include decreased NICU admission, 31% chance, as you can see, of decreased death, 34% chance lower risk of respiratory distress, and dramatically lower risk of early systemic infection, IVH, and necrotizing enterocolitis. So those are the benefits, which obviously we all know and we've talked about for years. And recently, there is a potential long-term negative effect, which includes mental, social, and behavioral disorders that have been shown to be greater in patients that receive steroids than did not receive steroids. And therefore, we really want to be cautious about those to whom we give, especially if we're giving it and it then falls outside of that 7-day window.
Richie, as a perinatologist yourself, myself as a hospitalist, I think we used to be very quick to give steroids, and it was just the first thing we did, and it was an easy decision. But now, as we're trying to time them a little bit more, do you find that you get a lot of phone calls from hospitalists or generalists in the community with just that simple question on steroids? And is that a question that you're comfortable addressing, or does that seem to be a burden for you? Just that simple question: does this patient meet? Is there enough risk for me to initiate steroids?
Thanks, Charlie. I think that it's definitely a question that should be asked, and I think that it's a shared decision-making between the hospitalist and ourselves, especially including the patient. What I've noticed more recently is that the educational process of what I convey to the obstetricians is a little bit behind, meaning the desire or the motivation to give the steroids is still there. And sometimes I'll get called, especially maybe after a weekend, that a patient was admitted and they already received the steroids, and now we talk about the plan. And then I sort of give that education so that the next time it doesn't necessarily happen in that order. I'm very amenable and open for those calls at any point, because I do think that we should be a little bit more hesitant to be giving it as quickly. And as we get further along in terms of feeling more comfortable with what we're seeing, I think we will cut back on the aggressiveness that we have about steroids and try and really time it better. One of the things that I tell patients is that we're pretty good in certain cases, especially with an educated patient that comes in earlier and someone who's worried, et cetera, of delaying delivery at least for 24 hours. If they don't show up 7 centimeters, 8 centimeters dilated in active labor, we're pretty good at stopping it for enough time to be able to get some steroids on board. And I think that it's not an all or nothing potential. But if we give it too early, then we have to worry about the patient coming in and then not benefiting from steroids. So we really have to balance whether or not we give it because we think the baby's going to deliver within 7 days, or we think that the patient may be able to come back and get benefit of steroids, even if we don't give it prior, because we're afraid of missing that 7-day window.
Yeah, I think my group certainly had the knee-jerk reaction of giving steroids to everyone, and our maternal fetal medicine partners were kind of on board with that. But over the last couple of years, we have really tried to time that administration a little bit more specific for certain patients. So I haven't seen that trend.
So the special statement from the Society of Maternal Fetal Medicine regarding the quality metrics for optimal timing of steroid administration says that we recognize that a major knowledge gap exists in our ability to accurately predict which at-risk patients will give birth within 7 days after evaluation, as we just discussed. And many factors must be considered, including the clinical presentation, which we know we are as good as we can be. We're not very accurate in prediction. Ultrasound findings, including cervical length, and then the laboratory findings, including the serum chemistries, the blood cell counts, the urine, as well as fetal fibronectin.
Yeah. Jessica, curious in your hospital, the ones you work at, surrounded by, how many hospitals have the ability to get cervical lengths? Are there hospitalists who are available for cervical lengths, or is that something difficult to come by?
So, working at a teaching facility with residents, we, always have somebody at hand to be able to get a cervical length. However, I have worked in facilities and private facilities where we don't have in-house hospitalists or obstetricians. And so you're putting in that order for a sonographer. And sometimes, you're competing with patients in the emergency department that are needing a sonographer, and you could be waiting hours for a patient to get a cervical length if you don't have, especially if it's at night and you don't have a provider in-house that's able to do one immediately. So there's definitely variation depending on the practice setting.
Charlie, Charlie, do you feel comfortable at bedside doing a transvaginal ultrasound and looking at the cervix when you're in-house as a hospitalist? Do your colleagues feel the same as well?
Somewhat. As a group, we tried to get clear certification for cervical length, and it was difficult. The images you had to send in had to be very specific. So some of us were able to get it, and some of us weren't to get that certification. But apart from that, yes, we can get cervical lengths, but I think they're difficult at times when they do go down to radiology. I don't always love the images I see back. So I think cervical length is a good piece of data to collect, but I don't always feel super comfortable putting a lot of weight on it. When our perinatologists are in-house, which is during the day, I do put a lot more stock into their images and the data that they're able to give us. But no, it's sometimes difficult. Our availability is not always what it could be to capture a cervical length. And then again, like Jessica said, radiology, you're competing with a lot of other patients that need imaging. So the timing of a radiology cervical length can be difficult.
And even the level of the resident who is at the bedside in the teaching hospitals is going to be, generally triage is run by an R1 or an R2. So it's not, again, nothing against the residents, but they don't have the experience necessarily to be able to, and I don't know how well they are trained. I can tell you as a perinatologist, and we do cervical lengths all the time. And there are some that are very, very difficult depending on what's going on. It's not always easy to just look at a picture and know from the picture that it was done properly. So I think there are definitely difficulties when it comes to ultrasound cervical lengths.
Yeah.
Mm-hmm.
Jessica, do you want to talk about kind of the approach to the patient, maybe when they show up in triage, and how protocols may be helpful, like in what we were just talking about? Do you call the resident? Do you call the MFM to do the cervical length, et cetera?
So one of the challenges that nursing typically faces is that, each provider can tend to want something different. That compounded on maybe having new nurses, having travel nurses, somebody that's recently switched from day shift to night shift, and they may do something different on a different shift, can make it hard to really standardize care in patients. And then that's when we run into issues, right? Where one patient may get an FFN, a cervical length, an AFI, and another patient may just get a cervical exam, which is not what we want to optimize safe patient care. And so really having a preterm labor protocol in place takes away that guesswork, takes away that Dr. Smith wants this and Dr. Jones wants this, and really helps standardize things so that any nurse that's at the bedside can have a protocol to go off of and can ensure that each patient gets the same thing. It also takes away the guesswork of trying to, if you do have an FFN, and you utilize FFN at your facility, keeping in mind that just because we can collect it doesn't mean that it has to be sent. But once you collect it, you have the opportunity to collect it. So if you can't, let's say the provider that you're calling is in the OR at the moment with another patient at the moment, stuck in a delivery, and you don't know if that's something that they would want to send at that point, having a protocol in place ensures that, one, you're timely assessing the patient and you're not just waiting for a provider to make that determination, but two, that you can collect it. And once you talk with that provider, you have it available to send, and you have another clinical tool to determine, does this patient need to stay? Do we need to do more interventions, or could they possibly go home? And
Jessica,
so, oh yes.
Jessica, do you and your nursing counterparts feel comfortable doing the fibronectins?
I have been doing FFN since I started before I became an advanced practice provider, since I started as a baby nurse. That was part of my orientation where I worked at the time. But there's certainly facilities where that is not the case. And so I think adding that on to it can be very easily collected, but accurate collection is important, right? And getting accurate results. And so I do think if a nurse works at a facility where not all the staff are comfortable doing that it certainly could be beneficial in providing in-services and routine, annual competency on making sure that people are comfortable collecting an FFN, especially if you don't have a hospitalist or in-house OBs 24/7, making sure that the nurse has a level of competency with that, because it's very easy to collect, but we want to make sure that it's accurately collected and that they really get to the back of the vagina, that posterior fornix reflection.
Yeah, I tell my nurses that until they have a positive result, I'm not sure they're putting it in the right place. So
yes, that's a great way to think of it.
And Jessica, I think something that goes along with that education too is the education piece about how important a fetal fibronectin may be to that individual patient. That may be the piece of data that tips the scales for whether that patient's going home or whether that patient's coming to the hospital. So empowering the nurse to say, you are going to collect a test that could really impact how this patient's care goes for the next 3 to 4 days is an empowering statement. And letting them know that, yeah, this test matters and your ability to collect it matters to this patient. I think that's always important, that they're just not collecting swabs for no reason. This is a big piece of this patient's care.
Absolutely. And, most patients, a cervical exam is uncomfortable. But FFN collection, for the most part, is not incredibly uncomfortable, can be done very quickly. And it is important that the nurses can speak to that. And like you said, and tell the patients why they are collecting it. Because, especially for a patient that is working, has other children at home, having that piece of information that you're 99% unlikely to deliver within the next 2 weeks, and allowing that patient to go home is huge when they can spend that time with their kids, their family, do other things versus sending somebody home that actually needs to be there. We absolutely don't want to do that. And so I think it gives the patients reassurance. And I think as a nurse, that's what you want to do. You want to be able to reassure your patient. You want to be able to educate your patient. A lot of times the patient can be frustrated as they're waiting to see a provider. And anything that you can do to help alleviate that frustration for the patient really helps to build that confidence in the providers caring for the patient, the nurses, the team, and helps alleviate the patient's stress.
Once they're already having the speculum exam for the genital cultures, the wet prep, the GBS, ruling out PPROM, it's a pretty straightforward test. So if the protocol, as we have on the screen, is being followed, the FFN is really an easy adjunct that doesn't really take any extra time.
Absolutely. And, I have even seen some of our providers send patients from the office with the FFN collected. Richie, can you speak to that? Do you do that in your practice?
Yeah, so I have patients that really kind of fall into two situations. One are the patients that we're following because of a history of preterm delivery, let's say, that we're following cervical length serially. Those patients, before they have their cervical length, my sonographers know to get me or one of my practitioners to do a swab beforehand. Again, once that transvaginal ultrasound or a digital exam is performed, it's too late to do the fibronectin, and then the whole paradigm is shifted. And so they know that even if we do, for example, when we're looking to rule out placenta previa on a patient at 28 weeks, I have them get me beforehand, because who knows if incidentally we're going to find a short cervix. So those are the patients that we're doing it sort of on a prophylactic level. And then I have the patients who come in and we ask them, is the baby moving? Sure. Are you feeling any contractions? Well, I feel a lot of pressure. How long has it been going on? Going on for a few days. And so in those patients, if they sort of meet a clinical criteria where I feel that there may be something going on, or if we look from above and the cervix looks like it may be changing a little bit, then I will do a fibronectin, then do the ultrasound. If the cervical ultrasound then makes me nervous enough that in either case, in other words, it was long before, or the clinical presentation and the cervix don't match, etc. If that's the case, then what I will do is send the patient to triage with the fibronectin in hand. The main reason for that is it saves them having the fibronectin when they get to the hospital. We've already done the transvaginal, so they can't have that done anyway. But it also allows the hospital to run the sample, which comes back much quicker than it would if I sent it to the referring lab.
And Richie, even that patient who you see in clinic who's been having some contraction, who may be there for a routine visit, but having some contractions, not sure what to make of those, even if they get a fetal fibronectin in the office and then go home, now she has some reassurance. If she does have a negative fetal fibronectin and has contractions later that evening, some reassurance that maybe I can watch these a little bit longer, don't need to rush into the hospital because she had a fetal fibronectin within the last few days. When she calls into triage, speaks to a nurse or a provider, she can give that piece of information. Well, I did have a fetal fibronectin that was negative 3 days. That may change how aggressive we are in having someone come to the hospital or not.
Without a doubt. And we do that all the time as well. There are the patients that you throw the fibronectin away. They're the patients that you send to the hospital with the fibronectin. And then most people kind of in the middle, where you send it off for the reassurance of getting it. And I think it's important to understand the frame of mind that you have when doing a fibronectin test. Jessica mentioned it earlier, you get 99% reassurance that the patient's not going to deliver. The negative predictive value is really what we're looking for, right? We're not so great on the positive side of things. We're pretty good, but not great. But on the negative side, that patient can really sleep with confidence, as you said, that they're not going to deliver within the next 2 weeks if it's negative. So even from that perspective, any patient that has a little bit of concern, whether, again, it's because of her history, whether it's because of symptoms, whether it's because of perceived symptoms, sending off the fibronectin helps give them that reassurance.
Yeah. And just getting back to the protocol, I have been a hospitalist. Two of my sites are more downtown, tertiary type of sites. My other site is more rural. And before we had a protocol, I could get a call from a nurse from any of these sites, and I could be in the middle of a difficult C-section, and I get a phone call wanting to know to alert me that there's a patient there for preterm labor evaluation. What would I like to do? Well, all the things that we have listed on the algorithm here, protocol here, is what I would like to do. But when I was in the midst of a busy C-section, that's a hard thing to get back to that nurse. And sometimes those pieces of information are lost or missed, and the patient doesn't get the proper evaluation. So implementing a protocol at our sites has been really, really reassuring for the providers who know that the patients are going to get this evaluation every time. It's so much easier for the nurses to know exactly what they're supposed to do. Patients get evaluated quicker because we're not waiting for callbacks. We're not waiting for hospitalists who are busy in a delivery or in a C-section evaluating other patients. So to streamline this, to Jessica's point, to give the nurse the reassurance that they're doing the right things for these patients is really a game changer.
It also, I think, delays or prevents patients from being sent from the periphery, from your rural areas to a tertiary care hospital, when I remember many times patients would be sent because they didn't have a fibronectin done and they were banging out contractions, and the hospitalists or the privates in the other hospitals were nervous, and they'd send them down. The patient would come in, we'd watch them for 12 hours. We just feel guilty sending them home right away. So we'd watch them overnight and then send them home the next day. And it was really a waste of a transport. Sometimes they would fly by helicopter, they'd come by ambulance, for that distance. And we would just tell them, well, I think everything is fine, you can go home. And so it does prevent that from happening as well.
Yeah. And you never know who's going to want this information. So, a nurse talking to an individual provider, that may not be where the story ends for that patient. That provider may need to take that data. Let's say it's a midwife, and that midwife may need to come to me as a hospital and say, this is what I have. And I may want some other data that midwife may not have collected, or I may need to go to the perinatologist. I want to be able to go up that chain and have the most amount of information available to present to make a good plan for that patient.
And I think, kind of piggybacking off of what you said, having the most information to give to the next provider. A lot of times when I'm reporting off to a physician, they're seeing a lot of patients. We're all seeing a lot of patients. And so they need to make a decision based on what I tell them very quickly. And so the more accurate information that I can give them quickly, the better the throughput for the patient. Instead of having to go back and then say, well, let's get this. Well, let's also get this. Because what no patient wants is to just sit there with multiple people coming in, telling them different things or not getting a definitive answer. And then somebody just saying, well, we're just going to keep you overnight and watch, but we can't really say if anything's wrong with you. That leads a lot of frustration for patients.
We want to keep our triages moving, right? We want patients to come in, get evaluated appropriately, and then move along, whether they get admitted for observation or they get sent home. Patients don't like to sit there for 3.5 hours and wondering what's going on, waiting for information, having tests repeated or tests that weren't collected eventually done. So they want a complete evaluation and a plan made, and that's what we all want for them.
What's the turnaround time in your hospitals to get the fibronectin back?
We're at 30 minutes. So if that's done, by the time you have that done, you have the cervical exam done, you have the initial phone call done, you may or may not have an IV with some fluids, and you have 30 minutes of a tracing and a TOCO tracing. Now you have another piece of data to already work off of.
Yeah, go ahead.
Go ahead, Jessica. Well, I'll let you finish. We have a real-time question that I want to bring into the discussion here.
Awesome. I was just saying, I worked at both facilities that use FFN and those that do not. But those that do, about 30 minutes is the turnaround time, which is pretty rapid in a hospital, in any hospital setting. 30 minutes.
Nothing gets done in 30 minutes in a hospital.
No.
So we've had some real-time questions that have come in here, and I want to use this one to kind of guide the discussion a little bit. But the question is, could you address and explore the difference between inpatient and outpatient use of FFN?
Yeah, I think we touched on it. I think that the FFN, I guess I'll speak to the outpatient because that's really more of my wheelhouse. The outpatient FFN management, as we said, is really geared towards making patients feel more comfortable or sending patients who are uncomfortable both in their minds as well as in the practitioner's mind to be able to go to the hospital and save that decision-making process. Meaning, when I speak to the hospitalist or the private physician whose patient I'm taking care of, and I send them in, I say, I'm really worried about this patient. She came in with a lot of pressure. Her cervical length, is, I don't know, 0.5 centimeters, and she has no risk factors, and she's 26 weeks, as we talked about in the case discussion. And I'm going to send her in right now. She's coming with a fibronectin in hand. Send it off to the lab. Hopefully 30 minutes later, you're going to have a result, and then you'll be able to monitor her for the contractions, et cetera. So I think from the outpatient side, I think it saves a lot of patients from having to go into the hospital, because we're going to get a result in, let's say, 4 hours, or let's say within 4 hours of doing the exam in patients that we send it to the conventional labs, and we get it in 30 minutes for the patients that go to the hospital that we're much more concerned about.
Richie, do you have patients that you follow regularly where you're doing every 2-week fetal fibronectins?
So the answer is yes, but I'm not necessarily sending them. So
Okay.
I have patients, for example, like the one in our case, who have a history of a 26-week delivery in the past, and that patient now is coming to me, and we're doing serial cervical length starting at 23 weeks, which is really, I guess, I'll say the cusp of viability, where I would intervene with steroids, and it's different in every hospital. But at that point, I will start doing a fibronectin before doing the vaginal ultrasound. If her symptoms are minimal or none, and the cervical length is appropriate, then I throw the fibronectin in the garbage and I send her on her way. If, on the other hand, there's any changes, then I will send the fibronectin and send her home. And of course, as I said before, if she has symptomatology that makes me believe that something more concerning is going on, I'll send her with the fibronectin in hand to the hospital. There are no patients that I can think of that I just send it off for reassurance. And the reason I don't do that is because if you have a long cervix that's 3.5 centimeters long and you're asymptomatic, I am worried about getting a false positive and having to figure out what to do with a false positive in a patient that I really wouldn't do anything anyway if I didn't send the test. I do tell residents, never order a test that's going to come back and bite you in the rear. And so I try to follow that advice and not do it myself.
Yeah. You want to go back to the algorithm?
Hey, go ahead, Charlie, please.
Yeah. So after all that has been collected, and we're doing the fetal fibronectin prior to the cervical exam, prior to transvaginal ultrasound, in this algorithm, it has vaginal ultrasound, the decision to do one based on the fetal fibronectin result. I don't think all algorithms, all hospital triage areas are working that way. Some may do things a little bit different. I've seen protocols where if the cervix is long, like Richie mentioned, that the fetal fibronectin won't even be done because you have a long reassuring cervix. Or if you have a very short cervix, less than 2 centimeters potentially, that patient may be at risk enough where a fetal fibronectin may not be necessary. But for the patient with that middle of the road cervix, 2 to 3 centimeters long, is where it's very valuable. Again, different algorithms, depends on how your system wants to set up. But that lab result, the fetal fibronectin result, certainly will help you then move on to, are you reassured? Does this patient need further evaluation, and or does this patient need admission to the hospital?
Charlie, I'd like to jump in there for a second, because I think that it's really important what you just said, and it's actually one of my pet peeves, which is whether the cervix is 5 millimeters long or 25 millimeters long. I think that the test is an adequate or an excellent test, not even adequate. I used to say, I said to the residents, I said, FFN does not care what the cervical length is. Meaning, it's not, if you look at the data, cervical length helps give us more reassurance, but it does not change the result of the fibronectin. I have had many patients, and I can't even count them anymore, who have had shortening cervixes that have been 1.5 centimeters, 1 centimeter, that have had negative fibronectins. We have not put in the hospital. We may have put them on pelvic or sexual rest. We may have had them not exercise every day, but we did not take them out of work. We did not do anything to change their overall function. And they've made it to term without getting steroids, without getting anything, because the fibronectin was negative. So I would be much more aggressive about, I think this is a test that you either believe or you don't believe. If you believe it, then you believe it for all of it. You don't believe it for some of it. I've had many times where, someone took the fibronectin, they have a 1.5 centimeter cervix. It was done properly. They send it off. It comes back negative, and they decide to treat anyway. Those are the things that really are disturbing to me, because again, if you're sending it off, then you believe it. If you don't want to believe it, I guess that's up to you. Again, I believe it and I use it in that way. And I think that when one has more experience with using the test and feeling that there's, I guess, attending safety net behind you and perinatal safety nets behind you, that you have the ability to watch and wait and see what happens, I think you can start feeling more comfortable with it and treating a negative as a negative all the time, not just based on the cervical length.
Yeah, and that's the flow that we use. We use the fetal fibronectin first, using the cervical length later if we feel like we need it. We're not getting cervical lengths and using just that as our information. So I would agree with you in that sense.
And I think that all, just comes back to just making sure that you accurately collect, if you're going to collect an FFN, that you collect it accurately, that you have people working to assess the patient, whether your facility has nurses doing that or your facility has providers doing that can accurately collect that FFN and have that option to have that information available to the patient if you're going to choose to use that test.
Jessica, when you train new nurses to do FFNs along with the training that that they're otherwise assessing, how do you train them to do the FFN?
So I always say, as soon as a patient comes in, obviously you're going to get their vital signs, and then put them on the monitor, and then get that speculum out, collect your FFN, make sure that, and a speculum will really help make sure that you are all the way in the vagina, that you're getting to that posterior fornix, the back of that vagina, because you can see deeper in than the patient just laying down, and everybody's body girth is different. Sometimes you may think you're deep into the vagina and you're really not. But to accurately collect, we really want to be at the back of the vagina. And so I will say, collect your samples. If your facility, if their process is to get a wet prep, get all of that up front, your FFN, your wet prep, and then do your digital exam and do things in that order. So if you're doing a preterm labor assessment, vitals, patient on the monitor, collect your FFN and your wet prep or your other specimens, then do your digital exam. And then, any other testing, whether that's, cervical length or not, can come after that, because then you have, if you just always do it in that order, you've minimized the chance of the patient being exposed to gel and getting an inaccurate result.
How long does it usually take for the nurses to feel comfortable doing the speculum exam?
Once I think that really depends on each facility. Those facilities that may have a really small unit and may not have a lot of opportunities to do a preterm labor assessment. I live in Texas, so with some of our rural facilities, the same nurses that are taking care of labor and delivery and postpartum and triage are also taking care of like your gynae patients and med-surg patients. They're kind of doing it all. So certainly in those settings, because they don't assess patients they're not seeing as many pregnant patients to assess for preterm labor as frequently. they feel really comfortable like after doing the training, and then if they don't do it for a while, then they start to feel uncomfortable. Those facilities, really even those mid-level facilities, because I think everywhere we see patients that come in enough during their pregnancy with complaints of contractions, or where they're concerned for preterm labor, and so I think with that additional practice, very quickly they are able to gain comfort in routinely doing it.
Gotcha.
Ease and comfort, and once that is established, I see no issues.
Great. So if we go back to the case study that we started with, I think what we've just spoken about gives a little bit of pause to the way this patient was taken care of. Charlie, do you want to kind of go through and say how you would have taken care of this patient differently?
Yeah, certainly. I mean, this would be a patient who would be, if you fall into that algorithm, which I would like to do with her, would have that evaluation up front with that fetal fibronectin, with a cervical exam that was closed and soft, even without the cervical length here. If we had a fetal fibronectin that was negative, which I'm assuming most likely in this patient's case, this patient would have had a negative fetal fibronectin, we would have saved her an admission to the hospital, potentially a transfer to the hospital. If this was a rural site where she was evaluated, we would have saved her magnesium administration, betamethasone administration, and the remainder of that hospital, and maybe a little bit of that patient experience that she was brought to the hospital. Her child at home had to have extra help. Her husband had to stay out of work for 2 days to get this done, as opposed to some reassurance where she could have gone home, had close follow-up, and then eventually delivered at term like she did.
Cool. Next slide.
And I think it's just important also to keep in mind, it costs nothing to collect and discard the test. Where the charge comes in is when you actually send it. If you collect it and don't end up using it, there is no cost to that to the patient or the facility. So I think, especially as nurses, a lot of times it's really drilled down, to be fiscally responsible of resources and not just collecting things to collect them. But there is no cost to the patient just to collect it if you discard it. And so it's always better to have more information than not enough.
So I guess we have a couple of key takeaways in summarizing. It's difficult to predict preterm birth. So use as many resources that are available to you. The key to this test is to identify the low-risk patients. So as Jessica said, conserve resources and minimize intervention. I think we've really talked about that extensively today. Better prediction of preterm birth within 7 days can improve the timing of steroid implementation. And then I think we've given a really good idea as how all clinicians in the OB setting, all practitioners, nurses, et cetera, can encourage standardization and improvement of the preterm labor assessment. I think it's really important that, as we did today, to sort of understand the perspectives of everybody and be able to work as a team to be able to provide the best care.
Absolutely.